This is a 60-year-old gentleman that came to me as a Hep C consult from another from his PCP. He's a really nice fella, 60-year-old gentleman with Medicaid, who has a prior history of IV drug use. He's been sober for a little bit over 4 years now, suspects that he acquired hepatitis C about 10 years ago. He was sharing needles at that time with somebody who was known to have been infected. So he's had it for at least 10 years that he estimates, but could have been longer than that. He was just discovered on routine screening. He has had his first of two in the Hep A series, and we've begun his hepatitis B series. The only medications that he takes are Flomax. His labs are relatively unremarkable, with the exception of his FibroSure, which was an F4. His viral load's 2.5 million. His vitamin D actually came back low, and he's being replaced. He's negative for HIV. The reason that I really wanted to talk about him is in these people with no history that ever suggests decompensated liver cirrhosis. I always wonder how far to go with those people when they have a non-invasive test that suggests compensated cirrhosis, like this gentleman. I don't know. He's going to get a right upper quadrant ultrasound, really just to screen him for hepatocellular carcinoma. We have no reason to think that he has hepatocellular carcinoma, but we'll get him imaged. Is there a reason to do an upper endoscopy on this guy, on an asymptomatic gentleman with no history of bleeding or of anemia? We're going to get a colonoscopy for him because he's old enough to need one anyway for just routine colon cancer screening. But I'm always curious as to whether or not getting GI on board with a gentleman such as this is necessary. As far as treatment options for him, his genotype is 2, so Epclusa or one of the pangenotypic medicines would be reasonable for him. But I was just kind of curious as to what everybody thought.
Thank you so much, Dr. Peters. Any thoughts, comments, questions? Dr. Rushton, I noticed you unmuted.
Yeah, I did GI for a lot of years in the past, and I would think this patient who's undergoing a colonoscopy, it would be convenient with F4 to check for varices. Perhaps it would be more of a question if he wasn't going to have the colonoscopy, but I think you could do a double on the same day, just for that reason.
Hey, Dr. Peters, this is Kaylee. I'll tag on to that a little bit. And I think that's a really good question, because historically, when we've presented at ECHO, we've always kind of said, well, first assess, do they have cirrhosis or not? And if they have cirrhosis, they need to be getting those hepatocellular carcinoma screens every 6 months through imaging, and then referred for an EGD, which, kind of universal testing that would make sense at kind of a beginner level. But actually, there's a lot of data now that's saying you don't necessarily have to screen for varices if their risk is low. And so really with those patients, and I'm not even sure if he even has liver cirrhosis, like you said, with a non-invasive marker that says F4, his platelets are normal. I don't know if you calculated his APRI, but I guarantee, once his Hep C is treated, if his LFT is normalized and you repeat a fibro test at SBR12 or later on, you're going to see that number reduce. I think that's an overestimate. The caveat to that would be is if his liver imaging showed any nodular contour or any heterogeneity of the liver, or even any collateral circulation or portal hypertension, any signs like that, or even when you see him, if you have any clinical signs to suggest that he's got, any kind of portal hypertension, like the spider nevi, or noticeable like abdominal vasculature, because if you think about, with cirrhosis, you can have well compensated advanced liver disease or even cirrhosis, but not, the earliest kind of complication or sequela of that is going to be that portal hypertension, which essentially leads to complications such as varices. And even in patients that have cirrhosis and have varices, the risk for bleeding is low if they're small. And that's kind of the end game, is a decompensating event. One of those would be variceal bleeding. And so I kind of think of it as more like risk stratification. Does this person have decompensated cirrhosis? If yes, absolutely get an EGD. If not, or if even there's some question, does even really have cirrhosis? There's actually, and I can't remember the name of the screening tool, but essentially if their platelets are above 150, and you get an elastography and it's less than 20 kilopascals, the risk for bleeding is low, that you can just defer that EGD. Now, in this gentleman's case, if you don't have access to the elastography, which I know that's still something we're limited in West Virginia, I would get his ultrasound first. If you note any signs that are consistent with advanced fibrosis or cirrhosis, and he's already getting that colonoscopy, I think Dr. Rushton had a great suggestion. You can just do them at the same time. But otherwise, if his liver appears normal, there's no signs for portal hypertension or concerns on imaging, then I believe you can defer that EGD for now. And then I would repeat the fibro test just to see if that improves once his hep C is treated. I know that's a long answer, but we don't need to do EGD in everybody.
Thank you so much, Kaylee, for that awesome feedback. Anyone else with some comments, recommendations? And Dr. Peters, were there any other things you wanted addressed about this case?
Yeah, that was really it. He's a relatively straightforward case with the exception of that. But I run into that from time to time. These people that either you get what you in this guy, what you suspect is an overestimated sense of how advanced his liver disease is, either based on history or based on the other labs that you have, or imaging. And I'm always just wondering whether or not I really need to refer all of these people for EGD. So it's nice to hear that there's some evidence that that's unnecessary, because I always feel like we're sticking scopes when we don't need to do that necessarily. Now for him, having to do a colon, or finally convincing him of the need to do a routine screening colonoscopy is good. But it's nice to know that there's not something specific that I'm missing.
Awesome, thank you. Any other comments before we go to the second case?
I had presented some patients to Dr. Feinberg a few times, and with higher F scores. And by the time she got done with it, she said these were not compensated cirrhotics, but just overestimates. So going by the FibroSure, especially at this fellow's age, I think probably be good to have the ultrasound. I think I would certainly agree with, but I think maybe these tests sometimes overestimate the degree of cirrhosis, if any.
I agree, Dr. Rushton. They certainly do. I mean, next session, I'll finish my talk on fibrosis and genotype assessments. But a fibro test, I honestly don't like to use it unless we don't have access to an elastography. It's not a cheap test, and there are several things that can impact it to be an overestimate. So I tend to get an APRI and a FIB4 as the quick calculations you can just do with a CBC and a basal metabolic panel. And then elastography I prefer, because that will actually assess for the liver stiffness, but also give you a picture. So your imaging modality helps you assess the contour as well in that vasculature, like I said. But when we're limited, we're limited. And so I think a fibro test or FibroSure still has utility if we don't have access to the elastography, but I tend to not go with that one unless I don't have another non-invasive assessment to use.
Do we have more than 3 of those machines in the state yet?
Yeah, we do. We have several now, but I'm not sure. I'm not sure where all of them are located. I think that what I've heard is a lot of gastroenterologists throughout the state actually have that offered within their practice now. But I don't have a list of providers. I know of a few, and I can provide a list to the group of the ones that I do know that are present in the state. But yeah, it's still not as accessible as it should be. It's pretty much standard of care everywhere else now. We just don't have that same accessibility in West Virginia. But I'd be happy to give you a list of the ones that I know of, the locations I know of, and then if anybody else knows of any place else, we can certainly keep adding to that.
That would be great. Would you say that elastography should be done on every patient? Would that replace any other testing that we do? Would it replace FibroSure?
Right. So about each of those tests is about $450. And so I tend to, when we used to have the insurance restrictions to where we could only get treatment approved if they had an F score of 3 or 4, I used to get both to try to get patients more access to treatment in hopes that we could go with the worst number. Now that that's changed and we just have more access to treatment, I tend to do the imaging modality in most patients, and then only check a fibro test if I don't have access to that. Or if someone's obese, a lot of times that body habitus can impact the elastography to where you might not get a great picture, but there's a lot of factors that can overestimate the fibro test as well. So I tend to get the APRI and FIB4 on everybody, just because those are quick calculations that can help kind of categorize whether or not they have cirrhosis or advanced fibrosis, I should say. And then I go with an imaging modality most of the time. The only time I don't tend to get an ultrasound of the liver or elastography is if somebody's had one, already done when they come in to see me, or if it's somebody that I think's been infected pretty recently. So if I have a 25-year-old that probably just got exposed to Hep C within the last year or two, they don't have any transaminitis, then I usually defer that because I wouldn't expect to find anything normal, and go ahead and get their Hep C treated. But most times I do imaging.
That's excellent. Thank you so much for that information, Kaylee. All right, Dr. Peters, I can pull up your second case for you, and same thing, just let me know if you'd like me to scroll up or down.
Now, I wanted to present these two cases on the same day because they're so similar. In fact, these guys are only about a year apart in age. The difference in this, of course, he's 61-year-old gentleman. He has had imaging that showed some coarsening of his echo texture and fatty liver changes. Nothing to suggest malignancy a year ago. He has known he's carried this diagnosis for 20 years. He doesn't really know exactly when or how he would have gotten it. He does have a history of military service. He's been in prison, and he's had many fights with many people that probably had hepatitis C in the past, which was a much better story than the other guys. It was better to listen to. His only other comorbidity is some hepatic steatosis. His medications are listed there. He takes some melatonin for sleep, and he follows in a pain clinic. He's on a PPI, which is of interest once we look to get him treated. He's immune, and he has been vaccinated and is immune to both hepatitis A and B. He's not terribly overweight. In fact, he's less overweight than you might expect for somebody that has hepatic steatosis. His labs, again, relatively unimpressive as far as that's concerned. His viral load was higher, Vitamin D was actually, it turned out to be fine. In this gentleman, it was over 40. And he, I think, was taking it over the counter vitamin D. So he's just going to continue with that. He's negative for HIV. His genotype 1A. I was actually kind of expecting him to have genotype 3, since if I remember right, I think it's the one that can cause fatty liver changes by itself. Although now I'm not sure, but he's genotype 1A. He's over 6 million. As far as what to treat him with, we were thinking either Epclusa, like the last gentleman, or Mavrite in him. We'll discontinue his PPI during treatment, and it was kind of the same thing. I mean, as far as whether or not I don't know, with his ultrasound being somewhat abnormal, an upper GI in him might be indicated. He just had a colonoscopy a year ago, so I don't know that he's. I talked to them about that being a possibility, but wanted to see what everybody thought.
Awesome. Thank you again for that. And I can pull up the case as well if anyone needs to refer back to the labs or anything. But any feedback, comments, or questions for Dr. Peters?
Hey, Greg, have you checked his cholesterol lately?
I can pull it up on him real quick. Hang on one second.
While he's looking for that, I had thought of another question. I mean, you pointed out he's not that overweight right now, but was there a time in his life when he was more overweight, and would that fatty liver be a remnant of that? Or, does it automatically get better when you lose weight?
That's a good point, Dr. Rexroad. While Greg's looking for that, this is Kaylee again. Yeah, with hepatic steatosis, I mean, the things you think about, the contributing factors, certainly being obese, which, like you said, he's not, having high blood pressure, hepatitis, viral hepatitis, alcohol use, high cholesterol, diabetes, that kind of sets that milieu for that steatosis to develop. And to be honest, if a patient loses even 5 to 7% of their body weight, that can really have significant changes and improve that fatty liver tissue. The thing that we get concerned about is, independent of hepatitis C that he has, that soon she'll be treated, is that fatty liver going to improve as well once his hepatitis is treated, or is that damage going to keep progressing? So the patients that I worry about that have fatty liver disease after Hep C is treated, I still think it would warrant, in his instance, I would still get ultrasounds every 6 months as a hepatocellular carcinoma screening. But if he didn't have more advanced evidence of fibrosis, I would still probably do an ultrasound annually, just to assess, to make sure that that fatty tissue hopefully would be improving. But, because that can still be an independent contributor to progression of fibrosis. If his liver enzymes stay elevated too, that could be also from the fatty liver. And so those are the people that have that chronic inflammation with fatty liver that I worry about them having problems with cirrhosis or decompensation later on, even after the Hep C is treated. But truly, the treatment for fatty liver is really lifestyle modifications, controlling blood sugar, blood pressure, cholesterol, losing, like I said, 5 to 7%, which seems, it might say they're 200 pounds, that's like 10 pounds, and set a goal of over a couple months. And I mean, that it tends to be, when you break it down to smaller goals, a little bit easier to achieve than just saying, oh yeah, I lose 50 pounds, or you got to lose weight. And it's kind of like patients are left to the wayside about how do I do that? The reason why I was asking more so about the cholesterol too is just because, statins with, when we think about portal hypertension and cirrhosis of the liver, a statin would help for his cholesterol management if it's elevated, but also with improving endothelial dysfunction. And so there's still even some utility to statins, even though we think, oh, don't use statins if they have liver disease, unless they have really significant transaminitis, you really should push for statins in these patients too, to help with their cholesterol and really managing their liver disease.
So his total cholesterol was 241. Triglycerides were elevated at 184. His LDL was 174. HDL was a little bit low at 30. I also checked an A1C in him, which was not completely normal. It was 5.9. But not. I'm trying to see if he had an old one. I don't think he did. I think that was the first time he had one.
Didn't realize I was on a mute. Yeah, thanks, Greg. I think
Sure.
I would kind of consider potentially a statin in him, but I would really try to treat his Hep C first, reassess, if his liver enzymes improve or normalize, that's what you would expect. Repeat that FibroSure or Fibro test at SVR12. And then also I would probably follow his platelets, because they can sometimes dip just from having Hep C also. If all of that improves by SVR12, and isn't worsening, I don't necessarily think he would need an EGD. You could always consider it, but if he's a little bit reluctant since you just got scoped again, I think you've got enough objective data that even if he did have varices, they would be small and he wouldn't really be at an increased risk of bleeding. But I would make sure to still counsel him on fatty liver management in hopes that would improve as well. Oh, and get an ultrasound in 6 months probably to just monitor his liver contour and another cancer screen.
Would you say, Dr. Berner, that the patient with mild varices is at, although there may be a lesser risk of bleeding, would you not start treatment with the appropriate beta blocker or otherwise?
Oh no, absolutely. Yeah, non-selective beta blocker. Typically propanolol or Inderal we'll use. Well, we don't use, but our gastroenterologists will use. But if they're too small to band, then really the goal is to decrease that pressure. And like I said, a statin too to help with the endothelial dysfunction. But no, still treat. Yeah, even if they were there, if they were present, still treat with a non-selective beta blocker.
Any other comments or thoughts from the group?
Hey, Greg. Great presentations. It's John. Yeah, both of those cases speak to, just the challenge with the discrepancy between non-invasive biomarkers, and the reality is we don't know which one to trust. The first case had a APRI of about 1, just eyeballing it. I'm not sure what the normal AST is for the lab that was doing that particular test, but just if I guesstimate, it's about 1, and the APRI for the second case is almost 2. It's like 1.9-ish. And there's honestly room for clinical feel too. The first one feels less cirrhotic than the second, and otherwise I copy and paste everything that Kaylee said. Great stuff. Oh, and one other thing, you still give the best social histories ever. I mean, I just want to understand the dynamic of how you get in a fight with somebody and then they just decide to disclose they have Hep C. I mean, how's that go down? I'm not sure about that one. Usually you're not going to fight with somebody that close to. But anyway, I've not been in any bar fights. I'm not sure. Maybe that's just part of the routine.
That's a really great point, Dr. Gelfus.
Very medically pertinent point.
I love it. Thank you all so much. And Dr. Peters, any other thoughts you wanted to share with the group about this case in particular before we move to the didactic?
No, in this guy's case, for some people that either don't have access to prescription drug coverage, or they don't have insurance. I always make a point in anybody with hepatitis C to ask about military service, because as I understand it, that's something that the VA can really help people with at times, can really help get access to those medications. And this guy wasn't in a situation like that where that needed, he's got access to it otherwise, but it's something to kind of keep in mind, because that's been successful with others. But now beyond that, that's all really helpful. I appreciate it.
Absolutely. Thank you so much, Dr. Peters, for the awesome case presentations. Truly appreciate your time on that. All right, Dr. Gilfus, I can either make you co-host and you can share on your end to advance your slides, or I'm more than happy to share on my end as well. Just let me know.
Sounds good. I can do it on my end. I forgot to mention that last case. We don't mention Harvoni very often. It's a genotype 1A. Obviously, viral load is above 6 million, so you couldn't do short course. But certainly, and it's a cirrhotic patient, probably, maybe, perhaps, but you could always give Harvoni. Mavorite, to the fellows listening, sometimes we seem to move away from Mavorite in cirrhotic patients, but you don't have to. Remember, it's really decompensated cirrhotics that you want to avoid the protease inhibitors, and preferentially go to Epclusa. So, yeah, but hey, Mitra, if you don't mind, I'm going to share the screen.
Absolutely. We'll turn things to you now. Thanks.
Cool. And I'm going to apologize to Carmen Rexroad and Greg Peters and Dr. Rush. Anybody who's seen this too many times, I apologize. I'll try to, I put some extra stuff in it. So there'll be some exciting parts, I hope. All right. Does everybody see the full screen? We
Yeah.
good? All right. I'm going to make this talk really easy. When HCV treatment is deferred, don't. There we go. One-liner. Don't defer treatment. Treat people. They do well. That being said, there's definitely time periods when we have to, either it's forced upon us by a payer or a patient's living situation or something. And how do we take care of those patients? What do we need to concentrate on? And remember that we try to not defer therapy. And we move away from this triaged approach where we had concentrated primarily on degree of liver disease, extrahepatic manifestations, and decreasing risk of transmission. And we're really trying to treat everybody who we can benefit with these medicines. And the reasons why is as such. We can prevent progression of chronic liver disease, i.e. fibrosis, and therefore the risk of hepatocellular cancer, decrease all-cause morbidity and mortality. And one of the ones I like the best is improve quality of life, regardless of baseline fibrosis stage. We can impact extrahepatic manifestations. And then there's the very noble concept of treatment as prevention, which has made its way into the mainstream of HIV and is moving slowly but surely into HCV treatment as well. Concept that you cannot transmit what you don't have. So I just put this up here because we're blessed. West Virginia, we're lucky. Actually, it's wonderful to be able to say that. We don't have a state anymore that encourages a triaged approach based upon fibrosis. I went to that website, the state of hepc.org. There are still states across our country that do engage in fibrosis-based restrictions. I won't call any out by name, but if your name's, never mind. There are a couple. Punchline is there are a couple. Ones that you'd probably be able to guess. That's all I'll say. And anyway, unfortunately, there's still issues across our great country. I am going to ask for participation here because this is the list that I can come up with for reasons to defer therapy. And by the way, I'm going to go back 2 slides and see I've underlined the word chronic. Probably, in all honesty, the most common reason we currently defer therapy is because we don't have an easy way to set the time scale for a patient's Hep C. And remember, chronic Hep C is defined as 6 months or greater of persistence of RNA. And if you diagnose a patient at one point in time and you don't have a definite acute hepatitis or any other way to sort of age that infection, a lot of payers are going to make us wait to prove that the patient has chronic Hep C. And it's not going to be one of these 10 to perhaps 50% 50% of people that's going to clear it out of natural history. So I don't have that on this part. So this is basically reasons we might defer chronic hep C therapy. And again, one of the points that HCVguidelines.org brings up is that they say, while treatment is certainly okay, how about we plan this to be a temporary deferment and revisit those obstacles periodically. And I think that's well said. So in my own practice, the obstacles that have come in the way between immediate therapy for people I've seen is usually things like no stable address or residence. Remember, a lot of these medicines were mailing to people from specialty pharmacies, and that has been a real conundrum, whether it be they're in between residencies or they're living at a halfway house that in some way limits their access to mail or telephone. That's been a problem. Obviously, incarceration. Inability to agree to go get labs. I don't think I would personally would hold therapy based upon this, but Medicaid at least has part of their consent form that you'll get labs done. One of the other more common reasons that we forego therapy up front is that people have other issues taking precedence. That's really true for a lot of our patients with hep C that we diagnose in the inpatient setting who are undergoing active therapy for perhaps endocarditis or some other pyogenic sequelae of their injection drug use. Okay, these patient capacity to comply with treatment is by far the majority of reasons that we defer therapies. This is very patient specific. Risk of reinfection is not a great reason to defer therapy unless it's somehow really insisted upon by the payer. Remember, there's no medical reason that you couldn't treat a person twice, 3 times, 5 times if they reacquired it that many times. And we are very quick to educate people about the need to perhaps curtail activities from a PWID standpoint, from an IgU standpoint. But when I read about reinfection studies, it's interesting. There's a significant proportion who reacquire this via sex or other high-risk behavior. So we just have to remember not to be judgmental on this risk of reinfection concept. And remember, from a medical standpoint, we should be able to treat this infection not once, not twice, but as many times as you need, as long as it's genuine, true reinfection. And those are arbitrary limits put on us by the payer usually. So risk of reinfection, I communicate that with patients as such. Medication interactions, Rachel Mitchell, I'm not going to try to bring her entire talk into a single line, but just remember there are very few medical interactions that are absolutes where we can't use some direct acting antiviral. Remember amiodarone and basically all the anti-seizure medicines, so some of the anti-arrhythmic medicines for the heart and brain. We do want to be careful with. Pregnancy, you have to have a patient unwilling to, or I should say willing to forego conception while on treatment, especially if there's ribavirin, but even as such, we don't have good data for the other drugs. If you had a decompensated cirrhotic patient, I know we've talked about that a lot. We want to be very cautious with protease inhibitor containing regimens. We probably only want to treat those patients after they've established with either a transplant center or a gastroenterologist, hepatologist. So that could be a significant delay, but worth it. Fortunately, this one, failure of prior treatment regimens, we have so many other options nowadays. I've not had that be a reason to defer therapy necessarily. You know, if you failed Harvoni, we can probably go to Mavorite. If you failed Mavorite, we can probably go to Vosevi. So we've got a lot of options. And then obviously not having insurance, we hopefully have ways around that one. The HCVguidelines.org talks about basically developing if, when, then treatments. So if you address X, Y, or Z, then we can undergo treatment. And this is a really good approach to try to keep people in care and keep them interested and let them know that there is a point at which they can come back and get treated. I wanted to open it up to everybody or anybody who is willing to maybe mention reasons that they've deferred therapy that are not addressed in this busy slide. If anybody wants to volunteer. Okay. So basically the rest of the talk is just reminding what we want to do for the care of the HCV infected individual. And, this is a challenging one. Prevent loss of patient engagement. Probably I'm the worst person to be giving that part. I'm a referral-based specialist. So I see patients only for their Hep C. And if I tell them I'm not treating their Hep C right now, they really lose interest in me quickly. But hopefully those of you who are primary docs out there see them for other reasons, and just try to keep them engaged. Absolute travesty in 2021 whenever we see somebody with a chronic viral illness that presents with end-stage sequelae. So we never want to see someone with HIV present with AIDS. We don't want to see someone with HCV present with cirrhosis. That's a lose. And a lot of times you'll see when they became disenfranchised at some prior bad encounter with a physician. So we want to try to make sure we keep them engaged. We want to make sure we teach them, and basically I will go through the rest of this stuff, go over natural history and education, make sure we address their primary risk factor, keep their labs up to date. And I've included a couple new labs on there I'll talk about keeping their screening for HCC up to date, vaccines, which there's one new vaccine I've recommended, assessing for symptoms, et cetera, et cetera. So this is sort of an outline for the rest of the talk. And remember, when we're seeing a patient, we want to educate them, both to comfort them that this is a disease process of decades, not days. But if you're seeing somebody who's already had it for decades, this could be a way to keep them interested. So if you're screening a baby boomer who apparently hasn't had risk factors for 30 years, this is one way to keep them coming back, remind them that the clock has been ticking for the last few decades. So natural history education, I always include on almost every visit with people. Transmission prevention. It's kind of exciting now that we can actually tell people that they could sign up as an organ donor with hepatitis C. That's pretty cool. But we still tell them not to donate blood. We do want to educate them each time, as long as they're viremic, that they don't want to share household items, including toothbrushes and et cetera, other personal items, cover any bleeding wounds. We again want to educate that it's not drug use, it's sharing of implements and paraphernalia that cause transmission. Regarding sexual transmission, this is, remember, particularly problematic in MSM with HIV positivity. Otherwise, sexual transmission of HCV is uncommon. And of course, re-educating about vertical transmission in our young women of childbearing age. This is again a slide I've shown Greg and Carmen and everyone else on here 10,000 times, but you can't overestimate the importance. And that is, remember what kills patients with HCV. What kills people with HCV is drug overdose and suicide. Humbling, always a good reminder to address whatever the risk factor was for acquisition, make sure that's in check. We all know that substance use is such a relapsing disorder. We want to make sure that we don't forget to make sure that a good place from whatever their ultimate risk factor was that led to the HCV in the first place. And I've learned from Greg Peters to give more Narcan prescriptions where appropriate. So thanks, Greg. Labs. So what labs should we keep up to date? Our echo form labs are pretty good to look at. There's a couple on there that I've recently added on after I've started giving a couple extra talks on extrahepatic manifestations. And so kind of routine stuff, CBC, LFTase, creatinine. But we should probably have a TSH on there every once in a while. So the thyroid is unduly affected by, and it can be hypo or hyper, by the way, thyroidism by HCV. Rheumatoid factors are a great way to screen for some extrahepatic manifestations and B cell hyperactivity, cryoglobulinemia, et cetera. And a urinalysis looking for proteinuria. Obviously, we can wait to see someone's having extrahepatic manifestations from Hep C on their kidneys when they start having creatinine elevation, but that's a lot later than checking for proteinuria early on. And of course, we want to make sure that they're not one of these rare people who has chronic Hep C that clears Hep C after 6 months. This does happen exceedingly rarely. I can remember, I actually don't know if I've ever seen it. Someone who's cleared Hep C on their own after they've developed chronic Hep C, but it's reported as it can happen. And usually the insurer is going to want you to prove, have a fairly recent Hep C PCR on the blood work prior to filling a prescription anyway. Remember to periodically screen for co-infections and those with ongoing risk factors. So HIV, Hep B are easy to remember, and RPR is less, it's not really going to be drug related, but potentially high risk behavior related. and then following the various modalities of non-invasive liver markers. I would not preferentially say any one of these, but just keep your liver fibrosis assessments up to date. And then obviously Greg's cases today were really pertinent from the perspective of who we need to keep our HCC screening up to date on, and whether or not we need to send patients for endoscopy. So remember, any F3 or F4 or greater, err on the side of caution. We're probably doing unnecessarily ultrasounds on some people's, but again, better safe than sorry. Vaccinations, the ACIP says basically for people with chronic liver disease, we want to do the vaccinations that are age appropriate for any other healthy individual, with the addition of some, and that the sum is the pneumococcal vaccination, the Hep A and the Hep B. Okay, so we want to make sure we vaccinate all our patients for hepatitis A who have Hep C. Remember the outbreak in the past couple of years, hepatitis A actually had a measurable mortality in people with a Hep C co-infection. And remember, Hep A is normally just a miserable month. You get better, you're okay. But if you have a Hep C co-infection, there could actually be fatal events. And we all know about the complications of Hep B and Hep C sort of combining to cause advanced fibrosis and some challenges with treatment as well. The new vaccine I have on there is the COVID vaccination. Certainly, I've actually had a lot of luck in this patient population of willingness to take the COVID vaccine. And so I'd certainly advise that you have this conversation with your patients with Hep C and point out that it's certainly they are considered potentially high-risk group for adverse outcomes, and advise vaccination. Now, this is a couple new slides. So basically, what we also want to do when we're seeing people that we don't treat is make sure that the hepatitis C is not affecting them in some way, shape, or form. And the three major ways hepatitis C can affect them is symptoms, number one. Number two, symptoms of chronic liver disease, that's cirrhosis, so symptomatic cirrhosis. And number three, via extrahepatic manifestations. I don't really talk more about the symptoms of chronic liver disease, but those would be sort of edema, edema, ascites, melena, hematemesis, spider angioma, and encephalopathy. But in terms of symptoms from hepatitis C, the most common ones: fatigue, myalgias, not feeling well, malaise. These are separate from symptoms of extrahepatic manifestations. I'm kind of shocked on how common extrahepatic manifestations are considered to be. That's probably because I must do a lousy review of systems and don't examine people well. But if you do a better job than myself, you can find extrahepatic manifestations in, gosh, a good percentage of people. Remember that extrahepatic manifestations from hepatitis C come from myriad mechanisms. Direct viral tissue damage. Remember, hepatitis C, while being named hepatitis C, is a systemic flavivirus that does have tropism for non-hepatic cells. So likes endothelial cells, likes some cells that are antigen presenting, like some leukocytes. So there are other cells in the body that HCV directly infects, okay? The other major ways in which HCV causes extrahepatic manifestations tends to be from immune system activation and the resultant inflammatory milieu, as well as induction of autoimmunity. So it's part of the autoantibody production that are unintentionally directed towards targets on our own cells, and then again, that chronic immune activation. A couple important things with extrahepatic manifestations is we usually treat them by treating Hep C, and very importantly, they may not correlate with the hepatic fibrosis stage. So you could have a person with F1 fibrosis and may not seem like an urgent thing to treat them, but they could develop an extrahepatic manifestation that could become eventually life-threatening. This is a little bit of a blurry slide, but kind of goes over the review of systems that you'd want to do and that you'd want to concentrate on for people with HCV infected areas. Probably in my mind, outside of the liver, the scariest extrahepatic manifestations tend to be hematologic, and that's because they include cancer. So a good test question answer for anybody out there is, what other cancers associated with hepatitis C besides hepatocellular cancer? And the answer is a B-cell non-Hodgkin's lymphoma. and we'll talk about that mechanistically. But you've got also cryoglobulinemia, ITP potentially within the hematologic review systems. The skin stuff, there's a bunch of rashes associated with it, lichen planus and vasculitic lesions and porphyria cutaneous tarda tend to be the most common ones. You can have a immune complex related GN that can progress to frank nephrotic syndrome, often presents with early proteinuria if you're screening. I mentioned the thyroid is a problem from extrahepatic standpoint, either hypo or hyper, believe it or not. And then glucose intolerance and frank diabetes. And believe it or not, this one, the diabetes actually tends to potentially be from direct cell invasion of the pancreatic islet cells. So HCV seems to have a direct effect on the pancreas. You can get dry eyes, dry mouth. I mentioned vasculitis. It can cause a neuropathy via mononeuritis multiplex. It does not tend to be a distal symmetric neuropathy. It tends to be an asymmetric neuropathy of a mononeuritis, and so on and so forth. And this is a cool picture that sort of shows the root cause, HCV, for all this stuff. And this top half is talking about sort of the immune activation and how that causes end organ damage. So you've got the virus, you've got antibodies, then you develop immune complexes, you activate complement, and all of this stuff deposits in vascular endothelial spaces and cause end organ damage. So this is the immune complex mediated component. The other half of this is this chronic immune stimulation can lead to a monoclonal expansion of a B cell population and get cryoglobulinemia and eventually potentially conversion to non-Hodgkin's lymphoma, sometimes stopping through a monoclonal gammopathy, but not always. When you're screening for sort of this stuff down here, which is nebulous unless your patient really presents with a frank vasculitis early on, how do you screen for cryoglobulinemia? The best advice I have found was start with a rheumatoid factor in an asymptomatic patient. If your rheumatoid factor is negative, you're done. But if you have a symptomatic patient who has cryoglobulin symptoms, and by the way, what are cryoglobulin symptoms? Cryoglobulin symptoms are things like rash, kidney involvement, and potentially arthralgias, so skin, kidney, joints. You would potentially, in a patient like this, continue to do your specific testing. So you kind of go down here, ignore it. But if your rheumatoid factor is positive, automatically go down and then look for cryoglobulins complement activation, SPEP, looking for a monoclonal gammopathy, doing your neuroanalysis, as well as tests for other chronic viruses that can also trigger positive rheumatoid factor. Okay, switching from the extrahepatic manifestations back into other generic advice we give people that we decide not to treat. We want to make sure they aren't doing anything else to insult their liver, so we'd want to have them try to maintain optimal body weight, exercise, avoid alcohol, and the other hepatic toxins. One of the more common things I've seen people do lately is take a lot of supplements to boost their testosterone. And I've had a couple people get liver enzyme bumps from those. I'm not really sure what's in that stuff, but I do know that testosterone supplementation is potentially hepatotoxic, and some of the stuff people are taking from GNC, we might want to tell them to be careful with. And just about how about assessing the fibrosis? We want to keep doing it. HCVguidelines.org does not say how often we want to keep looking at a person's sort of progression of liver disease, but just beware that the progression of liver disease varies from person to person depending upon a bunch of factors. That can be host factors, environmental factors, or even viral factors. And sort of, I split them up into host and viral ones here. The non-modifiable ones tend to be our age, our degree of inflammation, whether or not we're male or female. That tends to have faster progression if you're an older male. And of course, if you require medicines that suppress your immune system in some way, shape, or form. Semi-modifiable ones as well, as if you have glucose intolerance or a metabolic milieu that's setting you up towards non-alcoholic fatty liver disease, drinking alcohol as well. These are all things that can advance fibrosis more rapidly. Viral factors include having genotype 3 and having co-infections with other viruses like Hep B or HIV. Do remember that fibrosis progression does not always happen linearly. You can have someone who's F0, 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 F1, F3, F4 in sequential studies. So one of the best things to remember is that as patients get older, they're more likely to develop fibrosis. And after they start to develop fibrosis, that's more likely to beget further fibrosis. And so just keep an eye on people. You can use the activity grade. Remember, the activity grade is that part of the FibroSure panel that we don't look at as often. It's the A score, and the higher the A score, that may predict more rapid fibrosis. If you don't have a FibroSure or an ACTI test that you've looked at recently, you can also look at the serum transaminases, which largely reflect the same thing. The higher those are, the more concerning you might be. How often do we reassess patients? No one really knows that. If you had a person who has advanced fibrosis, F3 or greater, you're going to be seeing them every 6 months anyway, because you have to do hepatocellular cancer screening. And in those patients, they're kind of on the urgent end that you'd want to see them again and hopefully address whatever obstacles are preventing you from treating them. Otherwise, maybe every year for someone without a lot of risk factors for rapid progression, without a lot of fibrosis. Whatever it actually would take to keep them engaged, that's what I would say is probably the best answer. All right, and thank you all for your attention. Love to hear any comments or questions or reasons other people defer therapy, or any questions on the care of those patients.
Would you mind to clarify the slide that showed genotype 3 and deferment of treatment, or was that only if genotype 3 was in association with HIV or whatever was on?
Yeah, so I can explain that slide probably better than the slide. So basically, that was these were factors that can lead to more rapid and advanced fibrosis in one patient versus another. So genotype 3 certainly progresses more rapidly towards fibrosis than genotype 1, 2, or 4. And so that, and also HIV was listed, which should have been as a separate concept, can also lead to more advanced and rapid fibrosis versus someone who's HIV unaffected. So HCV genotype 3 versus other genotypes, and any HCV genotype with HIV co-infection can have more rapid fibrosis. And honestly, it can be disturbingly fast. I've seen a patient progress from F0 to F3 in 5 years who was HIV co-infected. So that definitely is not the norm for the natural history we educate patients on, that they have, 20 or some odd years before they really get advanced fibrosis in general. Remember, genotype 3, we tend to say takes about 10 years off the natural history. And that's, so as opposed to 20 to 30 years, maybe 15 to 20 to get cirrhosis.
That's very interesting, thanks. I'm getting ready to treat my first 2 patients with genotype 3 after I can get their second PCR.
Yeah, that's great. That's a really good patient population to treat. Be cautious if they come out with any estimate of cirrhosis. Remember, if there's any part of their clinical presentation that suggests cirrhosis, that is the potential patient population to be cautious with, and potentially even contemplate resistance testing. NS5A polymorphism testing.
Well, thank you so much, Dr. Gilfus. That was always a great refresher to have that didactic. So I know you apologize to us, those of us who have heard that before, but it's always so wonderful to have that refresher. So we appreciate it a lot. Thank you. We are at the end of our session hour, but if there are any other outstanding questions about the didactic or anything, just feel free to shoot us an email. Elizabeth and I are here to help in any way, and we'll make sure to have the questions addressed. The only announcement that I have is that our next session will be on May 27th, and Kaylee will be finishing her talk on why genotype and fibrosis matter. So keep an eye out for that reminder, and we'll see you guys next time. Thank you all so much.
Bye.
Bye.